Good day. My name is Zinaida Perić. I'm a hematologist and bone marrow transplant physician from Zagreb, Croatia, and I'm the chair of the Transplant Complications Working Party of the EBMT. I'm today here to answer a question on how can diet support a good transplant outcome. Well, I would start with saying that we know that malnutrition significantly affects transplant outcomes, so survival, transplant-related mortality, quality of life. And therefore, nutritional support is important. However, there are no clear guidelines on the nutritional support in stem cell transplant recipients, as there is limited evidence. And there's also a broad variability of clinical practices, and that we have learned several years ago when we conducted a survey among transplant centers on the nutritional support in the EBMT. And when it comes to guidelines, there are existing guidelines from the European and American Society of Nutrition, but they are pretty scarce. In general, they do recommend screening for malnutrition, and they do recommend enteral nutrition over parenteral nutrition and safe food handling over neutropenic diet. But as I say, this is not really always conducted in the clinical practice. When it comes to acute GvHD, traditionally we use nil by mouth in patients with severe diarrhea, but that is only level D of evidence, or an oral upgrade diet when safe, but this is also level C of evidence. And today we are questioning this strategy because what we see in similar patients, and these are patients with IBD, that these patients benefit from earlier dietary addition of fiber, vegetables, and fruits, and this really brings the hypothesis that GvHD patients could do better with early addition of fiber, vegetables, and fruits as well. Also, in chronic GvHD, malnutrition reflects severity of GvHD, and therefore malnutrition cannot be managed alone. You have to manage GvHD by a multidisciplinary approach, and therefore it is even harder to do in chronic GvHD. But nutrition is not only enteral or parenteral nutrition, it's also about micronutrients. Today we know important roles of, for example, vitamin A, vitamin D in pathophysiology of GvHD, and we have also learned from studies that the lack of vitamin D, for example, can lead to a higher incidence of GvHD, and this has enabled studies which try the supplementation of vitamin D prospectively in stem cell transplant recipients, starting before transplant, several days before transplant, and which showed that this really significantly decreases the incidence of chronic GvHD with no effect on acute GvHD, but with explanation that supplementation started late. Later studies have shown that vitamin D can modify GvHD incidence, but dependently on off receptor polymorphisms. Finally, I would like to mention what is today a hot topic in transplant, and that is microbiota. We know that this reflects phase 1 of GvHD pathophysiology because in phase 1 microbial products interact with antigen-presenting cells, and therefore it has become really interesting to target microbiota in order to prevent or treat GvHD as well. because in the transplant, microbiota changes significantly due to conditioning, antibiotics, GvHD infections, and we have dysbiosis, which means loss of diversity, loss of anaerobic commensals, and expansion of pathobionts, Proteobacteria, Enterococcus, Streptococcus, for example. And this dysbiosis has been related to higher incidence of infections, relapse, GvHD, delayed immune reconstitution, and in general reduced overall survival. And for that reason, as I said, it becomes really interesting on how to manipulate this microbiota and in order to improve transplant outcomes. One way is to feed this good bacteria, and that is giving them prebiotics, so non-digestible food which selectively stimulates growth of the good bacteria. And these are, for example, products as fructooligosaccharides, potato-based starch, and all these products are being evaluated in trials now, and we will see the results if this works or not. Finally, the use of probiotics is also very interesting. So the use of specific bacteria, as for example Bifidobacterium or Lactobacillus, in order to repopulate the injured microbiota, or actually the use of an ultimate probiotic, which is fecal microbiota transplantation, which has been shown to work in decolonization of patients from multi-drug resistant microorganisms, which can then potentially prevent GvHD. And also this has been shown to work also in steroid refractory intestinal GvHD in a similar way. So there are many perspectives for nutrition in transplantation, and we should definitely find ways to use them. So with this, I would like to end, and I would like to thank you for your attention.